is what solidarity is about. I'm going to base some of the things of what I'm going to say. I've compressed the objectives into a shorter one, which is to build an awareness and understanding of both the transformational power while acknowledging limitations, ethical boundaries. And a lot of it is inspired from in February, India launched a strategy for AI and healthcare for India called Sahi that we had a pleasure to be part of. A very small bit of background before we do a direct deep dive into where bias comes from. First, the promise of AI in medicine is not new. Ever since this article in 1970 and even before, people have been thinking that computers will become extremely helpful to doctors in sometimes replacing intellectual functions. You can see what Bill Schwartz thought about computers back in 1970. And of course, in 1970, what he had was things like this. It's an ABG discussion between between a physician and a computer. And based on these things, they thought computers were ready. They clearly weren't. And I'll try to convince you by the end that perhaps even now there is some gap that remains. I will be very clear that it's almost impossible to talk about AI in health without specifying which AI. When you look at all these AIs that are already in practice reading chest X-rays for you, they all fall in this category, the second golden age of AI. When I was showing you those conversations between physicians and computers for ABGs, they were in this phase of AI, and the basic idea of a neural network had started. We will not get into the details of this, but basically the second golden age of AI starts with Hinton showing how computers can learn themselves, and the third golden age starts with transformers that I'll come to a little while later. Whenever you want to think about health AI and its ethics and explainability, it's a very comprehensive topic. There are two ways to think about it, which makes it simple. One is think technology, other is think application. If something is wrong technologically, it will not succeed. But even if the technology is right, but you think it wrong about the application, again, things will not succeed. But these are two somewhat orthogonal axes. You can discuss the technology of AI for everything we talked about, the ethics, the explainability, the reliability, and the application separately. So one of the words that we use very commonly is, do we have a valid solution? And this is taken from the WHO Health Technology Assessment. It basically shows that it says safety, quality, performance, continuum, which you can see safety, then you get to quality, then you get to performance, then you get to effectiveness, and finally, you even have to talk about money. When we talk about bias and equity and ethics, you cannot ignore the purchasing power of people. And while we will not spend much time on it today, I do want to make sure that I say this to you. There is no equity, even for a perfect solution, if it is not procurable to the people who need it. So let's start with a technical view first. And this is complex, and we'll discuss each of them one by one. But there are 5 very distinct versions of validity. One is called construct validity. Are you actually measuring what matters? Internal validity. Within the data, even if you're measuring what matters, are you learning the right relationship? External validity. Yes, your model may have learned the right relationship in your data. Will it survive going somewhere outside? And the last two are very unique ones that we'll come to later, particularly in the context of modern generative AI. And of course, harm, when we worry about safety bias, is a property of the mismatch. You can have something with limited validity. For example, something can have low external validity, but if you're using it in exactly the same hospital where you train the AI, the harm is low. But the minute you take it outside, harm will rise. So you have to look at harm and ethics as a function of the previous 5, which are very technological points. Let's take them one by one because it can get quite complicated quite fast. And we are going to speak in the beginning on narrow AI, then I'm going to come to broad generative AI towards the end. And narrow AI does one thing well, but cannot do multiple things. The errors tend to be more predictable. With broad generative AI, they can do multiple types of things, but where they go wrong is difficult to predict. So let's take the very first example of construct heredity. Is the model measuring what matters? Let's take depression. Let's take frailty. Let's take lifespan. Let's take healthiness. Let's take sickness. These are all very nice words that a doctor understands. But when you want to train AI and you take a very large amount of data and you want to simply say, look at what makes patients become more severe. And when you think that you have understood all this, you know you're looking at severity, you might find that your data doesn't contain all the information that you need for severity. Then you could say that I know one thing, people in ICUs must be more severe than people not in ICUs. You could say if lots of money is being spent on somebody's care, they are probably sicker than someone on whom lots of money is not being spent. But you would be wrong, right? What you wanted to measure is severity. But severity is something that you will not be able to condense into one variable at scale. And what you might use is something that's a proxy. Many people, for example, use expenditure of being in an ICU to estimate severity. Now, this leads to a problem. Now, those of you currently at LNJP would realize that a person on the wards of LNJP might easily make it to an ICU in a private hospital if they had the ability to pay. They might not yet be in the ICU simply because there was no bed available. A person in the emergency room who has not been admitted for 24 hours may not be admitted not because they were not sick, but because a bed was not there. And this is a very famous problem that I'm going to show you a real paper of by Obermeyer about black and white people. And of course, then there is the last part. No algorithm can use information that was never measured. So for example, when you are trying to do prognosis and you're trying to estimate who will get a heart attack, well, you cannot estimate it from your population until you follow them until the time they've got a heart attack. Now, some people will use a proxy. They will say all people who got a positive stress test are the people who get a heart attack. So I'm going to substitute getting a heart attack for a positive stress test, but your construct variety of measuring what matters has shifted, and you don't necessarily know how much it will influence your results. So let's take a practical example because this can be difficult. So here is a particular algorithm that was used in America to see which patients are sicker and need extra attention. On the x-axis, you have the score coming from the algorithm. On the y-axis, you have number of active medical problems. Now you would note that this line, the dark line, that is a black people, and the yellow line, which is white people, is very far apart. It's statistically exceedingly significant. And what you see is that for the same score, a black person has more problems, and for the same number of problems, a white person has a higher score. Now, you would imagine that the person who built the algorithm was not racist, but they had the same problem I talked to you about in the previous slide. They decided to use expenditure and where you were in a hospital, admitted, not admitted, wards, observation wards, step down units, ICUs as a proxy of severity. And basically, poor people always receive slightly less care or sometimes a lot less care than rich people. Black people are poor. right? That's what we want to do. If you got a limited number of livers to give, you got lots of people who need livers, you want to give it to the person with the highest need who would benefit from it the most, and so. Now, if you were not thinking further about it, you could simply say, I will give it to the person who will die the soonest. You would not necessarily be wrong. At one level, you have need, benefit. On the other side, you simply have risk of death. Now, risk of death will always be more for older people. A young person is always at a lower risk of death, all other things being similar, compared to an old people. So what an algorithm and AI would do if you were to give this kind of a construct to it, would pick up risk of death from some measure, quickly allocate, and what you see is the reality of what happened in UK. Young people waiting for livers grew drastically, while old people waiting for livers fell. Earlier, these things were roughly similar. And then, of course, a ethical debate started because many of these young people were the people with genetic diseases who could go back to a productive life if they required it. The need to go back to a productive life may be different for a young person versus a very old person. And these are ethical human problems that using an AI to build constructs was possibly never even the right answer. Now, assuming that we have understood construct validity, which basically means, are you even using the data that you need to be using based on what you want it to be measured? Let's look at internal validity. Let's take an example where clearly the data is correct. Let's say we want to find whether a person has COVID-19 on a chest X-ray, and we feed it a lot of chest X-rays, many of them containing COVID-19, many of them containing other diseases. The construct is absolutely fine. You want to recognize COVID-19 on a chest X-ray. You are providing X-rays of people with the label of the illness that they have. But this does not mean that the AI will automatically be correct. AI is outstanding at pattern recognition. It's its strength over human beings, but it becomes a weakness when the pattern is an artifact and the AI cannot understand. Because the algorithm that people used to train it probably contained all COVID-19 X-rays from some hospitals, which might have been COVID-19 hospitals, and all the normal X-rays from other hospitals that were not COVID-19 hospitals. The most efficient way for the AI to learn to classify is to ignore the X-ray and look at the name of the hospital. That it's a very stupid thing to do is very obvious to a human, but an AI is simply being asked to maximize its accuracy in classification of the X-ray. It does not know better on its own. Very similarly, in another study, somebody was trying to look at severity of pneumonia on chest X-rays. Now, ICUs, the patients are too sick to be taken for normal X-rays, so they use portable X-rays. And a portable X-ray looks very different from a normal X-ray. AP versus PA, and then the general machines penetration is different. So very quickly, the AI system learned to say severe pneumonia on portable X-rays. Again, something that was an internal validity problem. You provided it with the right set of data, but there were multiple variables, and some variables were very strongly correlated. The pattern was learned, but they were the wrong variables for the AI to be. This is internal validity. Now, when you come to large language models, and we'll do that later, they're particularly susceptible because they're trained on so many things that you have no idea what the relationship they are finding is. And the last part I will say, which is very important for ethics, is that where you're going to apply these algorithms with internal validity concerns matters a lot. You could take a pure correlation and perhaps use it for prediction. But you certainly should not take a pure correlation, because we do that. I mean, there are many things in this world that we don't know why they work, but we know they work. But when you are going to make a very critical decision based on it for treatment, you may not want to use things that are purely correlates and nothing else. Now let's talk about the next problem, which is external validity. External validity is your model is trained well, it works on your data, but it might fail when it goes to another place that has a different type of a data. You could train a beautiful AI to work in voice in a hospital where people speak in English or make notes in English. It'll immediately fail. In a hospital where people do not speak in English, you could do the same thing in X-rays. You could take X-rays in a very place where the X-ray machines are all digital. You could go to another place where the X-ray machines are analog, and you will find the AI does not. Now, the big challenge of this for ethics is that external validity is the biggest concern when the place where you're going to use the AI is in the actual patient population where you plan to use AI is not a bureaucratic add-on to delay people. It is an absolute technical requirement for safety and equity. And we'll come to all this later again. But this is key for ethical use and external validity. So construct validity, internal validity, and external validity together are the three classical validities that while evaluating whether a model is appropriate, ethically created, fair, unlikely to create inequity, you must check. And these are checkable. This is something that a doctor can learn how to do. There is nothing very technically complicated about this. But now let's move to something that is indeed difficult for everyone. Forget about doctors. Let's talk about transformers, which is basically the beginning of generative AI, which leads to different validity problems. I'm having two lines over here. The dog did not cross the road because it was tired. The dog did not cross the road because it was wide. You can see the wide road. You can see the tired dog until GPT. And I use GPT-4 over here, which is basically because of transformers, pre-trained transformers. That's the PNT, generative pre-trained transformers. It was almost impossible for computers to suddenly understand that just because I changed the last word from tired to wide, it was earlier referring to dog, and now in the second line, it refers to the road. And this is because transformers built the concept of attention, and that's the very famous paper, the game-changing paper, Attention is All You Need. And this is basically how it works. Every word in a sentence is strongly correlated to another word. So for example, fluffy and blue go with creature, while verdant goes with forest. The values in the connections between words are very low elsewhere. This idea that things are connected and your attention should go from based on one thing to something else somewhere else in a sentence, or somewhere else on a page, or somewhere else on a gene sequence, or somewhere else in a long, complicated electronic health record is the basic idea of transformers and attention. What this allowed us to do was to throw huge amounts of data at computers and ask them to train themselves of tokens of data. A token is about 3/4 of a word when you're speaking in language. They use thousands of GPUs. Grok 3 was trained on 100,000 GPUs. To put this in context, all of India's GPUs are somewhere falsehood because people can't pick it up. And by the nature of what transformers are, hallucinations are a predictable property of transformers. It is not an incidental defect that we can fix. It will basically not verified truth. We can do a lot of things to reduce these problems and increase generative validity. But at the end of the day, humans become important in anything that is important. So risk depends on the user and the action pathway, not just the model. All generative models will hallucinate. A specialist can catch the errors. A patient deciding whether a chest pain requires emergency care may not. And those of you in the audience who have used GPT can see that GPT wants to agree with you. If you start by saying, I frequently get these pains after I drink a lot of beer. Today I drank beer and I'm having chest pain. Do I need to go see a doctor? It will very happily explain to you that after beer you get acid, and the gas in the beer makes the acid go into the esophagus, and the esophagus can create pain. That is a false chest pain. You don't need to go. It wants to please you. It is not always listening very carefully to everything that you are saying about. And then, of course, accessing factuality, completeness, appropriateness is something that humans can do much better. But it boils down to generative validity, where fluency is not correctness. So where does bias enter? We discussed multiple types of validity problems. We could have poor data, we could have wrong labels, we could have inequities. We talked about that. We could talk about measurement differences. We could have choices between narrow AI, broad AI. We could have deployment problems. But the key point I want to make is bias can come from all of these, but ultimately it is detectable and fixable. In the Obama paper I talked to you about, they changed the target. They removed many of the previous things and worked with real clinical data, and the disparity pretty much went away. It requires you to look carefully at the labels, at the targets, to think about all the three types of validities. In case you're looking at generative AI, test it rigorously, look at subgroup performance, and try to fix it. The last part of this section would be fairness and equity. And a model can be very accurate on the average, yet be unfair by failing specific groups. It could give you wrong results by sex, age, race, language, disability, device access. All these things would be called unfair. But again, you have to ask yourself a deeper question. For example, chest X-rays, all the AIs currently perform poorly in women compared to men. Now, part of it could be unfair because women are not adequately represented. But part of it could simply be it does have inequity, but it's a technically explained inequity. But again, what you would see from what I'm saying is a lot of thinking has to go into every one of these. A non-doctor cannot automatically figure it out. And this requires deep engagement between doctors and AI builders, and perhaps doctors should be the AI builders. And you should assess them at the model level. You should go to the field. You should look at whether it discriminates between rich women and poor women. For example, if all women are equally discriminated, it really is not a representation problem, because rich women probably would have been more represented. So my point is that fairness and equity are easy to talk about at one level, but also very difficult to understand. And last, everything could be perfect, but you may still worsen inequity if the models that you plan to deploy into the healthcare system are unavailable, unusable, unaffordable, where need is the greatest, and that's where governments come in. Now, explainability is something that you had in your objectives. I will tell you the promise, and I'll tell you the reality. The promise is that AI will become explainable, clinicians will learn to trust it, there'll be transparency, we will understand model reasoning. You have all seen heat maps on AI, which shows you the part that leads to a diagnosis. Those are called saliency maps. The way you build them is you keep removing the part and see which part removal changes the output, and you put a heat map on it. And of course, the last promise is that human in the loop will make sure that things will work. Let me tell you the reality. I do not see a world in which true explainability ever occurs in modern AI. Nobody fully understands how large foundation models work. We can test them a lot, but we can't explain how they work. And while we can build post hoc explanations after we see their errors, that's again plausibility without correctness. And the last part is, if multiple different things can lead to the same final output, then you cannot trace back a one original source from anything that's final. It's easy to write in mathematics. If there is a multi-correspondence on x side to y, then knowing y cannot tell you which x. It simply cannot be done. And anybody who tells you that a fully explainable AI that is understandable by physicians will be built is over-optimistic. In fact, in a issue of the 100th year of the NEJM, when they talked about the next 100 years in medicine, they very clearly spoke about future models being such that doctors will be unable to understand. To do is to look at reliability, rigorous validation. And that for doctors may be a better ask than explanation. Because if it's a mathematical explanation, we are not set up to understand it. And if it is in language, it simply cannot be done. Then, of course, the practice of AI workflow systems, human in the loop. I can tell you there are multiple papers already showing that human in the loop is not a guarantee of safety. At the point when the average accuracy rate of AI becomes superior to humans, humans quickly undergo automation bias. Because they're frequently wrong when contradicting AI, they start agreeing with everything that the AI says. And sometimes it's also convenient because you can get your work done faster. To their thinking process, working process, who are effectively not even using the AI, even if it's available for them. And then comes accuracy. As I said earlier, accuracy is not reliability. A model can be accurate but unused. It can be trusted but wrong. It could be efficient but inequitable. And in everything, we need to do proper local validation. We should do local trials, including pragmatic RCTs, if you want to look at clinical benefit. Clinical benefit is different from model accuracy. Your RCT, if all it's going to tell you is the model was accurate, it was not a good RCT, because an RCT should be looking at what happened to real clinical outcomes. And of course, this is a complicated word, risk-tiered governance. There'll be relatively safe AI doing safe things. The risks of being wrong will be small. There will be other AIs that are taking critical decisions. The risk of being wrong is high. The amount of oversight by humans will scale with risk. It will scale with uncertainty. Whether your AI is dealing with consumers or dealing with physicians, you will require different guards. And then AI is not a static thing. You have to look at any AI solution across an entire life cycle to be ethical and to be not increase inequity in society. Sometimes safety can be increased simply by telling the model to say no when it is not sure. The problem is, and we did a recent study that I'm not showing right now, where we found the model's assessment of how sure it is has very little to do with the error rate that it has. I'll leave you with certain levels that AI has already reached. This is Amy. Amy is trained on itself, with Amy the patient playing with Amy the doctor and Amy the critic to understand how to do history, evaluation, everything better. Amy Articulate Medical Intelligence Explorer by Google. There's a Nature paper from last year. Eventually became so good that if you took 100 objectively structured case exams with patient actors in 3 different countries, where the patient actor is either interacting with a primary care physician or with Amy, Amy actually outperforms the primary care physician. But this has validity problems. A patient actor is not a patient. Why is that important? A patient actor will try to present with a typical case. A human doctor may have seen a wider range of things, while an AI will be outstanding at picking up the typical things and never forgetting anything. If you like to think of things in terms of statistical distributions, very often Amy talking to itself can remove the tails, keep the center. A patient actor will sample the center, not the tails, but a human doctor could have done better. Similarly, healthcare is very rarely sought by patients only on a chat with doctors on a WhatsApp. Usually a doctor gets to see a patient. So this entire design is structured to benefit Amy. So you have to look at all the validities. So you would see that these validities are probably low for this particular trial, although it is very interesting. This I think we have covered. So what do we really need to do next? We need to make sure that, especially as we move towards more and more generative AI, we use models that we can deploy in India. These are called open weight models that you can take and you can deploy here. You saw what happened recently with Anthropic, with models like Fable suddenly being banned outside America or to even within America to non-Americans. There will never be a perfect AI for everyone. So what you need is massively online open validation. For those of you interested can look up Move and Annie Hartley together. Then we have to think about how our AI will work on all these 3 settings. There'll be AI that will be very good in this setting. There'll be AI that might be useful in this setting, but what works here will not work there, and vice versa. When we take a data, we have to see whether it is digitized data, in which case there might be lots of errors when we converted analog data to digital, or whether it is digital from native data, whether it is connected data, are we combining data? All these things we need to look at. And finally, if we imagine a transformed digital society that is ethical, we need to think about privacy and how AI algorithms move. I'm going to end by saying 2 things. It's an unanswered question: who should be using AI in healthcare? If you were to ask the West, they will say users of AI should be able to do the same thing without AI. If they don't know how to do it without AI, they should not be using it. If you take this definition, then your safety, validation, ethics issues are very small. But your scalability is limited. Beyond making your doctors, for example, more efficient, you can't really serve a larger patient base, and the public health value is median. The other view, and I'm not endorsing one or the other, it is something that we need to think about, and I like the word of risk-calibrated governance. I believe the answer could be different things based on different tasks and different AIs. The user is doing tasks they could not do without AI. So a healthcare worker who does not recognize diabetic retinopathy can be given an AI to help them screen for diabetic retinopathy. It's not a problem. Because ultimately, what can go wrong? The patient was anyway not users who cannot do a task without AI to ethically do that task with AI. There are concerns, safety and validity, that must be addressed before it's ethical. But on the other hand, Scalability is such that people do not have access to care. One must recognize it and incorporate that in the decision making on ethics. And this, of course, is a very want you to see on this is that AI trials are going up rapidly. But I also want you to see that India has not yet done a single high quality outcome-based randomized control trial. And that is something we need to do if we have to do more than just talk about these things for the country. And last, contrary to what people think, that the biggest application of AI will be in helping doctors with decisions and diagnostic augmentation, the most pragmatic application of AI will simply be in making the workflow of healthcare systems much easier. The evidence strength is very high, shown on the right. The potential harm is low, need is high, and feasibility is very high. Only other thing that comes close is screening or triage. And something that we don't talk about enough is probably medical education. But there is too few trials, only 2 of them so far. So I have not calling the evidence strength high, because 2 out of 2 is not the same as 14 out of 14. With that said, I'm going to along the same tide as thinking about the benefit and govern things appropriately and educate the public. Earlier, you had Google patients. Now you will have ChatGPT patients. No matter what you tell them, they will use it. So public education is going to be very critical. And unlike other medical technologies, this will bypass doctors and go straight to the patient. Thank you all very much.
Thank you, sir, for the in-depth talk on such a interesting topic. The stage is now open for any questions. We can take 1 or 2 questions. Anybody can just raise a hand or just type in the chat box.
Well, no questions means either directly
So
or
they're all
complete lack
assimilating
thereof.
what you said. They're all
Yeah,
trying to
yeah, that's
assimilate.
absolutely fine. That's absolutely fine.
Thank you so much, sir, for sparing
My
time for
pleasure.
us
My
and
pleasure.
for the great lecture and, helping us understand the topic and also telling us the scope that India has in AI-based studies. We are lagging behind, as you just said, that we hardly have any studies. So it should be a motivation for all the young people who are listening in to devise something and to do something in this field.
I
Thank you, sir. Thank you
temporarily
so
saw
very
one
much.
hand by Amit Kumar. In case that hand was not by mistake, Amit, you're free to ask what you want. Of course, that hand could have been by mistake, which it probably was. No, Amit's hand is up again. Amit, what do you want? Please go ahead. Oh, I have to allow Amit to talk. Okay, allowed to talk. Amit, go ahead. You can speak now.
Hello.
Yes, please speak. We can hear you. Please speak.
Okay, good evening, sir. Your presentation is very nice, sir.
Thank
I
you.
want to ask one question. Sir, you said that algorithms decide the workflow of the AI. And when a doctor is involved in training of AI, the results are more reliable.
Mhm.
So in India, are there any uh, places or some online some job or something like that where doctors are hired for training the AI?
So there will be soon. Will be a project called Praman, and already private companies in India do a lot of it. But for open training and validation, the same Move platform I was talking about is coming to India. Give it a couple of months.
Oh, okay, okay, sir. Okay. Sir,
So
is
there
the
is a, okay.
sir, is this ME ME AI is available for use for physicians, sir?
Yes, multiple ones. So, for example, Meditron is a free downloadable. It's also available directly through web interfaces.
Is
Then,
it paid, sir, or free, sir?
No, that is free. Metatron is free. You can access it through a variety of channels. A little bit of programming tends to be required. Now, among Google has made MedGem available. OpenAI started OpenAI Health recently on a limited beta. And so they are there. MedGemini is also there. And many of these are completely free in a trial version.
Thank you, sir. Thank you.
Thank you, sir. So there is one question by an anonymous attendee.
Yeah.
What are some of the benefits for educating people about AI?
The biggest benefit, I guess, is that people don't misuse AI and at least learn the basically correct way of prompting AI while trying to get answers. And they also understand that AI can hallucinate and they need to take answers with a pinch of salt. And very importantly, not feed the AI with their wish. Because the typical error that you see with people using AI is they've already kind of communicated. And AI is a very good friend. It tells you what you want to hear. So, so how to clearly and compare, clearly provide data towards AI, because these things will occur. And what is the right thing to do as a next step? And what the government will do down the line is to create trusted sources, benchmark sources, where to go to find out which are the most trustable sources of AI, like benchmark pages. Like, for example, Mayo Clinic website has been rated very highly by the US National Academy of Medicine and Google to contain accurate medical information. Similarly, the government will come out eventually with benchmarks that guide the public regarding where to go. And this will all become part of patient education.
Thank you, sir. Another participant, Mr. Raju, has asked, will AMI replace physician diagnostic skills?
Will AMI replace? So let me answer it the way. So will physician skills decline in the age of AMIs? And the answer is yes. Already papers are out showing that after clinicians were given AI tools and then the AI tools are withdrawn, their performance went down. So we can see that getting access to AI, then AI being taken away, leads to a decline in performance. That's a very recent JAMA paper. There is another paper showing that people who were trained from the very beginning with access to AI were unable to do tasks without AI. So that's the training part. On the other hand, there are variations on this. There are many things that, for example, bronchoscopy, endoscopy, people learn on patients. If AI simulators were used to train doctors in those procedures, they became better. Because this was a case of limited opportunities to train on humans using a simulator, the same way that you train pilots on flight simulators to make them better pilots. So there are two parts to the answer here, but generally, for typical medical tasks, dependence on AI, loss of skills, or failure to gain skills during training is a real problem, especially when it comes to history taking, remembering medication. In many ways, it's not different from being able to remember phone numbers. Once upon a time, I remembered at least 20, 30 numbers. Now I can barely remember my own and my wife's. I struggle to remember any other phone number. So that's the problem of smartphones. I suspect many other people may be suffering from it.
Yes, sir, we all do. Sir, I think we can take one last question by Mr. Amit Kumar. He wants to know, sir, can you guide how to reduce the hallucinations while using AI for patient diagnosis or care-related decisions?
There are three different ways and you reduce hallucination. Each refers to the cause. One is called grounding. When there is an ability to fact check, then you can either provide some kind of a internet type fact checking system that is typically done through an agent in an agentic workflow, or you provide a document which is called RAG, retrieval augmented generation, that constrains the answer. That's one. It can reduce hallucination. Second reason for hallucination tends to be that the AI loses context. So something called context persistence is used. And then, of course, is token sizes. With more reliable information, the better. Each of these three can be used independently in agentic workflow. And that's probably the best way to reduce it. But you can never completely make it go away.
Thank you, sir. Thank you for answering the questions so patiently. With that,
Thank you.
we'll end the session. And thank you very much, sir, for sparing the time for us.
Thank you. Bye-bye.
We have, you have to fill up one form, which we'll be sharing, a link for the post-test form. Everyone is requested to please fill it up. It will be used for issuing the certificates. And mind you, the certificates will be given only those who fill up the form. So please, it's a humble request from us, from the team, organizing team, to please fill up the form so that we can dispatch with the certificates. Thank you very much. You can just see in the Google form, in the Zoom link, the form will be shared with you. With that, we come to the end of the session. Thank you everyone for joining us for the session. This was our 11th session in Artificial Intelligence in Medicine webinar series. This webinar series is a collaborative initiative organized by the Medical Innovation Center, MIC, which is initiative of Maulana Azad Medical College, New Delhi, and iHub Foundation of Cobotics, which is a part of IIT Delhi, and World Health Organization Collaborating Center for Emergency, Critical and Operative Care, the George Institute for Global Health, India. Join our WhatsApp group for updates on future sessions. See you all next time. Again, a reminder for filling up the form. Thank you, everyone. Kindly fill up the form and we finish for the day. Thank you all. Wonderful.